Check.
Right. Good evening, everyone, and welcome to yet another CME hosted by PSK Meru branch. I can see the attendees are continuing to increase. I'd like to remind everyone to subscribe to this webinar on the PPB portal. It's titled PSK Meru Management of LTBI and Updates on TPT Regimens. Good evening once more, and welcome to yet another CME hosted by PSK Meru branch. Thank you for joining us as we mark World TB Day today on the 24th of March. And this day is marked to continue raising awareness for TB and the different efforts that are being put to end it. So just a reminder to subscribe to this webinar on the PPB portal. The title is PSK Meru Management of LTBI and Updates on TPT Regimens. Before we start, I'd also like to remind you to put any general comments in the chat box, and for any questions you might have, you can put them in the chat box or the Q&A. Our theme for this year's World TB Day is Yes, We Can End TB, led by countries and powered by people. Our topic for this webinar is management of latent tuberculosis infection and updates on TPT, that is treatment preventive therapy regimens. Our presenter for today is Dr. Timothy Muriuki, who currently serves as a hospital pharmacist at Meru Teaching and Referral Hospital. Dr. Muriuki also happens to be our PSK Meru branch chair. And in the upcoming KMPDU elections, he is running to be the KMPDU Upper Eastern Branch Secretary. And finally, in his free time, he likes to take a bit of time to impart knowledge to young minds at one of our tertiary institutions. So without further ado, let me welcome Dr. Timothy Muriuki to give us our presentation for today. Karibu sana, Daktari.
Thank you very much, Dr. Lewis. I appreciate that lengthy introduction. I do a lot of those other extra things during my free time, and I'm happy to serve the people of Meru and Kenya at large. Yeah, so today we have a good topic to discuss and talk about in depth. That is management of latent tuberculosis infection. And thereafter, we shall look at current treatments that have been put in place. That is a TB preventive therapy. TPT, as it has come to be known, is a regimental treatment approved for treatment of LTBI across a wide range of populations. Yeah, so today's presentation is going to be looking at the description of the disease, that is the latent tuberculosis infection. And we shall also look at the updates that have been onboarded, or rather been added to TPT in terms of management of MDR, or how do we go about carrying out TB preventive therapies in MDR, and also some aspects of introduction of 3HP for pediatric patients. So basically that is what we shall be looking at today. So we shall be welcoming questions at the chat at the tail end of this presentation. And we are hoping that we shall be able to share deeply, as well as get other insights from the wide range of practitioners who have gotten the opportunity to join today's webinar. As you have heard, I have the joy of being a presenter today. In terms of background, I have practiced at the HIV TB clinic or HIV chest clinic for at least 6-7 years during my earlier years at Meru Teaching and Referral Hospital. So I have a sizable amount of experience and contact with these treatments. Yeah, so without any further ado, I think we shall just go to the presentation. We shall just go to the presentation. Sorry. Yes, I hope everyone can be able to see the slides clearly.
Yes,
Dr.
you can,
Lewis?
Doc. Proceed.
Good. Yeah, so today we shall start this presentation, first of all, with an outline of the burden of LTBI, or rather the TB burden, and thereafter we look at latent tuberculosis. So we have an outline of the global and regional TB preventive therapy. We shall look at the basics of TPT, what it constitutes, which are the backbone drugs, and how are they administered. Then we shall look at the updates, the new TPT regimens, the rationale of why they have been adopted. We shall look at the eligibility, or what we call inclusion criteria. And we shall look at the pharmacology of some of these agents, including the fluoquinolones, levofloxacin. Thereafter, we shall be interested in drug-drug interactions. We shall look at the special populations that qualify for use of TPT and considerations that have to be taken into place when we are handling this therapy. Equally, there is no complete treatment without dosing guidelines or dosing schedules. So we shall look at both the weight-based systems and the age-based systems of administering these drugs. We shall also look at the adverse events. Those are the ADRs that may arise in the unfortunate event that patients react with these drugs. There is a small section on contact management, we shall mention briefly. We shall look at the roles and responsibilities of the county pharmacist and the sub-county pharmacist as actors in this campaign to manage and treat LTBI or latent tuberculosis. And thereafter we shall be receiving questions and answers. So the global and local overview. So globally, TB preventive treatment coverage has been gaining momentum since it was adopted as a strategy to control tuberculosis in the UN high-level meeting, or what is called UNHLM of 2014. So currently, 5.3 million people have been put on TPT, and an increased number of the same has been adopted continuously. So when you look at that graph there, we see the populations that have been adopted. The bigger bulk of users are persons living with HIV because of the obvious reasons of the fact that with immunocompromised states, then the patients are at greater risk of having the conversion of latent tuberculosis into active disease. So TPT has found a significant utilization among people living with HIV. Then, as we see, there are household contacts aged less than 5 years. That is the green bar. And then we have the household contacts above equal to above 5 years. Those are the blue bars. So as we can see there, the coverage among newly enrolled people living with HIV dropped from 68% in 2019 to around 58 in 2024, and a slight increment from 56% in 2023. Yeah, so maybe I can just introduce briefly and mention that latent tuberculosis is basically an infection that a patient hosts, or they have the bacteria, mycobacterium in their body, but it is in a dormant state. And that dormant state means that there are factors that can bring about its activation or its transition to an active phase. One of them being the reduction in general body immunity. It could also be like a comorbidity alongside the LTBI that can cause about the reduction in immunity, and other factors including nutritional factors such as malnutrition and such like things. So it is important to appreciate that LTBI is not contagious. It is not contagious. And ideally, there are no active symptoms to look out for because there are no symptoms associated with this illness. And as a result of that, it can be an illness that can be easily forgotten. Yeah, so in terms of diagnosis, it is detected through positive TB blood tests, that is, for example, with the use of IGRA or IGRA. Can also make a diagnosis using the TB skin test. That is I think that is the Mantoux test. And often, wherever you find positives among the two, it should be followed by a chest X-ray to rule out the presence of an active disease. I just felt that it is important to give that as a context background for latent tuberculosis. So today we shall be looking at the treatments, which we shall be taking you through briefly. Yeah, so in terms of estimates on TB burden, the estimates on TB burden are, this is information from the WHO in consultation with countries that pull this data. So total TB incidence in 2024 was 117,000. That is rate per 100,000 population. The total incidence in people living with HIV in 2024 was at 25,000 at a rate of 100,000. Rate per 100,000, that is 44. And MDR, or multi-drug resistant or rifampicin resistant tuberculosis incident in 2024 was 970, equivalent to a population of 100,000, that was 1.7. Then TB mortalities in HIV negative persons were at 16,000, equivalent to 29 per 100,000 population. So TB deaths in people with HIV in 2024 stood at 8,000, equivalent to 14 per every 100,000. So the percentage of estimated number of household contacts of bacteriologically confirmed TB cases on preventive treatment stood at 40%, that is 39 to 41 on the rate per 100,000. So this is the picture or the snapshot concerning Kenya as at 2 years ago. That is the year 2024. So total TB cases notified were at 96,865. DRTB case notified at 751. Pediatric case findings at 12,557, standing at 13% on the incidence scale. So when you look at that graph down there on the TB treatment outcomes in 2023, we see a cure rate at 73.9% of the notified cases, and a treatment success rate at 88.9%. So that is significant because it tells you that there are patients or persons who had this disease and for one reason or another, they did not attain cure. And we had a significant population of persons whose treatment did not terminate in a treatment success rate to 100%. So in terms of sector contributions, we observe that the majority of these TB notified cases, at least 76.3% were notified in public facilities and only 23.7% from the private sector. That shows you that there is an area where we can be able to increase TB screening and also enhance deeper knowledge so that we can be able to contribute to a larger percentage in terms of private sector engagement. Of the cases observed, 49% had a chest x-ray done, and of those cases, they had a chest x-ray that was done, a chest x-ray plus AI. I think that is an artificial intelligence intervention in terms of the chest x-ray reporting. Yeah, so I think for persons living with HIV, we observe that 98% of PL-HIV who were put on TPT were also on ART, that is antiretroviral therapy. So next we look at the number of persons or people initiated on TPT in Kenya in the same year 2024. So for PL-HIV, we had 114,664, accounting for at least 70% of PL-HIV. The on-household contacts, this could be this does not mean necessarily they are HIV. In fact, these are just contacts, a follow-up of contacts of persons seen in the hospitals. This number stood at 49,571, accounting for 26%. And an interesting figure of healthcare workers of 4,527, accounting for 3% of persons who are put on TPT that year. Prisoners and prison staff counted for 1,282, that stands at 1%, and other clinical risk groups, that's 146, that is less than 1%. So that is the total number of persons who are put on TPT, 170,190. So we shall be looking at risk groups and to be able to understand why this number is significantly low and why we need to have it higher. So TB contact management cascade. So this is a graph that is showing some data on the bacteriologically confirmed cases. That year was 50,453. Expected contacts was 151,359. Remember, this is a number that is projected or extrapolated based on previous encounters. And the fact that it is such a high number and we only had this 51,000 or rather 50,000 being bacteriologically confirmed tells you that there's a significant number of persons out there who are considered to be like missed opportunities for treatment. Yeah, so I think that is it for that. Then there is this a slide that is looking at the data from the UNHLM, that is the United Nations High-Level Meeting that happened in the year 2023. I think this is 2023 or 2024? 2024, yes. So this is a TPT coverage global versus Kenya. So this is a trend analysis. So what we see is that PLHIV newly enrolled on ART, less than 15 years, accounted for 70%, and less than 15 years up to 50% of those notified cases, they were put on TPT. Then expected eligible household contacts overall at 40%. So the global trend, I think for the household contacts was at 25%. And we had a higher uptake of TPT among persons living with HIV at 58%. So people living with HIV newly enrolled on ART, that means this was a concomitant treatment with the newly introduced heart treatment, stood at 58%. Yeah, so this is the guideline that was introduced by the National TB and Lung Disease Program. And this particular guideline was the first one intended to introduce a TPT on a large scale in the communities. And also it served as a teaching tool when we wanted to induct healthcare workers coming into this space of care and treatment for TB. So the TPT regimens at the point of introduction were 3HP. That was a 3 months of isoniazid and rifampicin given once weekly. Then there was 3RH, that is 3 months of rifampicin isoniazid, that is a daily dose, and 6 months of isoniazid, 6 months of a daily isoniazid for that particular population of persons who qualified for that. Could be like expectant mothers. I think those are the ones who qualified for the 6 months of isoniazid. So in terms of the basics of TB preventive therapy, so the tuberculosis infection, previously latent TB infection, is a state of persistent immune response to stimulation by the Mycobacterium tuberculosis antigen with no evidence of clinically manifest active tuberculosis. Yeah, so in terms of TB preventive treatment, treatment is offered to individuals considered at risk of TB disease in order to reduce that risk. I think that first point, it shows that there is no clinically manifest TB. So there is that aspect of dormancy I had talked about earlier. So the TB here comes as a result of the treatment, the TPT here comes as a result of screening. It also comes as a result of the identification of circumstances, like in the case of having a contact who had active tuberculosis. So in terms of TB disease, it occurs when a person exposed to TB bacteria develops signs and symptoms of tuberculosis. So any contacts, in terms of the contacts, there are any persons who has been exposed to an index case. An index case is a bacteriologically confirmed TB patient. So whether in a household, social settings, learning institutions, or workplace settings. And this happens by sharing the same enclosed living space for one or more nights, or spending frequent or extended periods together during the day within the 3 months before the index case started their current treatment episode. So I think that needs to come out clearly. We consider you a contact if all of these circumstances align. So this aspect of sharing the same enclosed living space for one or more nights, or spending frequent or extended periods together during the day within the 3 months before the index case started their current treatment episode. Remember, with tuberculosis, nowadays we have expanded the criteria to even look at general cough. We are now not talking about the extended coughs of 2 weeks and above. Any cough is worth being subjected to a TB screening. And if it comes out as a positive outcome, then the persons who had been living with such a person qualify to become contacts. So we see that 1/4 of the world's population is estimated to have tuberculosis infection. Now, 1/4 is a big number. If the world today has 8 billion people, we are looking at a population of at least 2 billion. That is the estimate. So it is a significantly common disease. So people with tuberculosis infection form reservoirs for a significant portion of the emerging active TB. And people with these TB infections are seedbeds of tuberculosis in the community. And thus the push towards early identification or early diagnosis, and which will lead to the eradication of these seedbeds. So in terms of the positivity of tuberculosis infection among healthcare workers, there was that study that was done in Kiambu County, was at 78%, and that is as a preliminary report. So there was that study that was done on healthcare workers in Kiambu County, and it brought out a very unique picture of a high TB burden among healthcare workers, but in this case, it was latent TB infection. So the proportion of the Kenyan population that is infected with Mycobacterium tuberculosis is yet unknown. But if we extrapolate with the global trends at 25%, then you can imagine a population of at least 55 million. A quarter of that figure means what's definitely more than 10 million people could be at that risk of having tuberculosis or the LTBI. So most people with TB infection are unaware of the danger that may have already quietly settled in them. So here we see an illustration of a healthy lung and a lung that has been subjected to TB infection or a latent TB infection. So a healthy lung has no lesions, but once you breathe in the bacteria from persons with active TB, initially you do not feel sick and you have no symptoms, but the bacteria lodges within the lung and then it starts to multiply, albeit it will be dormant, but it is there. So in terms of the risk of progression, latent TB infection can become active TB, making you ill and risking infection for those you live with. Remember those household settings that we talked about, living in close quarters, all of those constitutes circumstances where a person who may be with an active disease transmitting it to the other healthy persons. Yeah, so in terms of the rationale for TB preventive therapy, so the goal here is to reduce the risk of progression from TB infection to active disease, killing the dormant mycobacteria. So this here is what we can consider to be a curative outcome of therapy. So for TPT, it reduces the morbidity, it reduces the progression from tuberculosis infection to active TB disease, thus reducing the transmission of tuberculosis. So in terms of benefits, there is cost savings. Due to the treatment of active TB involves 4 antibiotics. For the TB infection treatment, it uses 1 or 2 antibiotics. So I think that is a very direct benefit here, meaning that at the stage where the disease is dormant, you don't have to expose these patients to the full spectrum of the active phase of the TB therapy. Equally, we see that mycobacteria bacilli are not actively replicating, and there is a reduced likelihood of developing acquired drug resistance. So that is an important part to bear in mind, that you are reaching these bacteria while they are in a dormant or sleeping state, and thus there is a very reduced likelihood of having active multiplication of the bacterium, which brings about the possibility of that spontaneous mutation to resistance. So in terms of the cascade of the care approach to scaling up PMTPT, so In terms of the prevention of active TB disease by treatment of TB infection is a critical component. So we have steps here, such as the identification. Step 1 is the identification of those eligible for TPT, and they're immediately to be linked to care. Step 2 is a clinical evaluation to rule out TB disease. This is ruling out active TB disease. And this is where now we introduce the use of X-rays. Yeah, because with X-ray technologies, you can be able to pick up a progressing disease. Then there is a testing for TB infection. Testing for TB infection here, like where we talked about use of TST, the TB skin tests, or the IGRA. That forms part of the testing. And the step 4 is initiation and completion of TPT. Yeah, so I see there is some charts. So I hope everyone is seeing the moving slides.
Yes, Doctor, the slides are visible.
Yes. Yeah, I think there was a chart that was talking about slides not moving.
They are visible. They are moving, Doc. Thank you.
Okay. Now, in terms of eligible populations for TPT, this is very important. So, at top of that list of consideration is people living with HIV. That is children aged equal to or above 12 months, adolescents and adults. Those are persons who have tested positive for HIV. The next population is prisoners and staff working in prison settings. Yeah, so these prison settings are what we would call congregate settings. Congregate settings because of the fact that a majority of these persons live in very close quarters. I don't want to use the term congregation because that is it has more of religious connotations or religious inclinations, but anywhere where there is such a gathering of persons, they are considered to be congregate settings. Next population of interest is the healthcare workers and other staff in healthcare settings. This is for the very obvious fact that they are continuously interacting with sick persons and most likely interacting with TB infected, actively TB infected persons. So next eligible population is all contacts of a bacteriologically confirmed pulmonary tuberculosis patient. And in particular, DSTB here being a drug-sensitive tuberculosis, as well as multi-drug resistant stroke rifampicin-resistant TB contacts. So if you've any persons falling within this particular category qualifies by default to be given TB preventive therapy. Then there are those clinical risk groups like patients receiving immunosuppressants. We observe these like in the case of persons getting chemotherapy, cancer chemotherapy. There are also use of other immunosuppressants like in the case of surgical skin grafting to prevent graft rejection. I think those are also populations of persons who use immunosuppressants. Then there is patients receiving dialysis. That's a clinical risk group. And then there is patients preparing for an organ or hematological transplant. I think we have mentioned that. And patients with silicosis. So patients with silicosis, I think this is the one condition we observe where there is a deposition of foreign matter on the lung tissue as a result of inhalation of these foreign matter on the lung. Yeah, so in terms of ruling out TB disease, we observe that symptomatic screening should be conducted for all at-risk populations. TPT should be offered to the asymptomatic individuals. Remember, we said TPT is definitely asymptomatic. But when you observe, if patients are falling within these criteria, then definitely they should be considered for treatment. Equally, you rule out those with symptoms. Those with symptoms should be offered TB diagnostic investigations and managed appropriately. And you also need to look out for TB cardinal signs, such as in children, where we observe cough, persistent fevers, weight loss, stroke failure to thrive, Z scores of less than or equal to 2, lethargy and fatigue, reduced playfulness or decreased activity, and also history of TB contact. For adults, we look out for coughs, drenching night sweats, fevers, weight loss, difficulty in breathing, unexplained weight loss, BMIs of less than 18.5 or Z scores of equal to or less than 2, chest pains, and a history of TB contact. So I think wherever you are doing screening, you need to have these at the back of your mind when you're looking at pediatric populations as well as TB, as well as adult populations. Yeah, so in terms of the screening algorithm for at-risk groups before initiating TPT, so this here is a screening algorithm. There are the TB signs and symptoms in adults and children that we need to look out for, like cough of any duration, persistent fevers, temperatures greater than 37.5, drenching night sweats, unexplained weight loss, as we had said earlier, difficulties in breathing. So from that particular identification of those symptoms, I think we need now to start at looking at whether the patient is symptomatic. If they are symptomatic, they are subjected to the TB and other lung evaluation for TB and other lung conditions as per the TB screening and diagnostic algorithms. Equally, if they are symptomatic or no, and if they are PLHIV, I think there are guidances down here, how you're supposed to subject PLHIV to TPT. So you, as a start, when you encounter these asymptomatic patients, you conduct a chest X-ray, and from that, you make a guidance on whether it is an abnormal chest X-ray, meaning alluding to the possibility of active disease. Then, if they are PLHIV, you subject them to the C-reactive protein test. If it is positive, if it is positive, they can then be further subjected to a TB test. If it is less than 5 milligrams per deciliter or unavailable, then there's a consideration of whether to be given TPT or not. Upon observation of a normal chest X-ray for HIV negative persons, here it is subdivided in terms of equal to or under 5 and over 5 years. If it is a normal for over 5 years, they are subjected to the TB skin test or IGRA. If it is negative, you provide health education. If it is positive, you subject them to TPT. So I think since I have already shared these in the Meru group, I think we shall also be sharing them to the wider group so that we can have a better understanding of this algorithm. Equally, I will be sharing this link. You can terminate to that link in the National TB and Lung Disease portal so that you can be able to download that guideline and to look at other algorithms that have been availed. So now we look at the current TPT regimens before the new TPT regimen rollout. So we have three regimens here. We have the 3HP, That is the 3 months of rifampicin and isoniazid, administered as a once weekly treatment for 3 months. It is offered to adults above 15 years. So this is the old information prior to the update. The 3RH is the rifampicin and isoniazid daily for 3 months, offered to HIV negative children and adolescents above 15 years. No, for less than 15 years there, I think. Then isoniazid administered daily for 6 months is offered to anyone with a contraindication to the use of rifampicin and rifampicin, and it will be offered to pregnant and lactating women for up to 6 months. Remember, this is the old regimen. So we shall be looking at the new TPT regimens as advised in the guidelines for 2026. So there is the new introduction of the 3HP for pediatrics and adolescents. So here we see that this is a shorter regimen. It is more convenient and an alternative to the 6 months as well as the 3RH regimens. This particular regimen was introduced through a memo or a circular from the director, I think the DIG at the Ministry of Health. So it was a circular to roll out new TB preventive therapy regimens. So those are the benefits, the shorter regimen. It improves adherence and enhances completion rates. It has a less risk of hepatotoxicity and reduced risk of drug-drug interactions. Equally, as a result of these convenient dosing, there are fewer facility visits, and it is used by all eligible children irrespective of the HIV status. So this is the dosing schedule. This is a dosing schedule for children within these weight bands. That is a weight band of 10 to 12 kg. So there is a dosage of 300 milligrams, repeated as two tabs. The isoniazid dosage here is 250. So the dosing schedule here for the 3HP pill burden using the 100 milligram isoniazid pill is at 5 tabs. And the daily pill burden of 3RH is 2 to 3. And the weekly pill burden of 3RH is 14 to 21 tabs. So this is a comparison between the 3HP versus 3RH. So we observe a higher pill burden with the rifampicin based daily doses. Yeah, so this is how the tablets look like. We have the brown tablets for the 150 milligrams of the 3RH. And then we have the dispersible 100 milligram tablets. The dispersible 100 milligram tablets for the isoniazid. So for the 3RH, that is the dispersible tablets of isoniazid rifampicin 50-75 milligrams. That is how it looks like. It's a brownish tablet. Yeah. Sorry, just checking if there were any questions. So now we look at the studies to support the use of this new regimen. So we observed that previous studies, that was the dolphin and dolphin toe studies, have shown the combination is safe and effective in adults. So co-administration with DTG can be given with 3HP without modifying the dose. Now remember, the reason why we talk about modification of the dose here is because of the risk of the rifampicin-based regimens being rifampicin or rifampicin-based regimens being enzyme inducers. So here we observe that with this particular study, it proved that you can use the DTG concomitantly with the 3HP without modifying the dosage here. That is that aspect of super boosting. So equally, it supports the immediate start of the 3HP among ART naive people starting a dolutegravir-based regimen. So the data for children was lacking previously, but they are now available, and evidence for safety, tolerability, and high rate of adherence to the treatment has now been collated. There's also a low rate of minor adverse events in children who started the 3HP. The Dolphin Kid Study interaction between 3HP and DTG-based ART observed a minimal or absolutely no risk of adverse events. Yeah, so there is this particular guideline issued by the WHO, that is the WHO Operational Handbook on Tuberculosis. It goes into the depths of the evidences and studies that support the use of 3HP in pediatrics. So in terms of treatment completion and safety, we see treatment completion and safety profile for once weekly 3HP regimen for tuberculosis preventive therapy in children and adolescents as a systematic review. So this is basically a good regimen that enhances adherence. It also has minimal risks associated with the co-administration to DTG. So in terms of target populations and eligibility for 3HP, children aged less than 5 years are who are household contacts of people living with bacteriologically confirmed PTB who are found not to have TB disease. So they are strongly recommended to be given the 3HP. Equally, children and adolescents aged 5 and above who are household contacts of persons with bacteriologically confirmed PTB who have found not to have TB disease. On the same, children 12 months and older living with HIV who are considered unlikely to have TB disease if they live in a setting with high TB transmission, regardless of contact with TB. So they are also strongly recommended to get the 3HP regimen. And infants aged less than 12 months living with HIV who are in contact with persons with TB and who are unlikely to have TB disease. On the matter of adolescents, we observe that adolescents living with HIV who are unlikely to have TB disease, including those on antiretroviral treatment, pregnant women, and those who have pregnant women who have been treated for tuberculosis. So all children living with HIV who have successfully completed treatment for TB disease are also eligible users, future users of this regimen. So the note here is that CAL HIV, that is the children and adolescents living with HIV who are rifampicin compatible antiretroviral therapy regimen, such as who are on that rifampicin compatible ART regimen, such as dolutegravir. And I am pleased to report that a majority of the CAL HIV have now been transitioned to these rifampicin compatible regimens containing dolutegravir. Equally, we see that all of these children or pediatric cases, they are not supposed to have TB symptoms, or they are supposed to be TB symptoms negative upon screening, and there should be no contraindications to isoniazid or rifamycins. So in terms of contraindications associated with the 3HP initiation, the first and foremost is active TB disease. So if there is an active disease, such candidates should be treated with the 4-drug TB regimens for the active TB disease. If there is any known allergy to isoniazid or rifampicin, equally that constitutes a contraindication. When we observe moderate to severe hepatic disease, equally patients should not be put on this regimen. Definitely contacts of MDR is there multi-drug resistant and RR is a rifampicin resistant TB patients. The advisory is to use levofloxacin as TPT, and we shall be seeing how it is used shortly. CAL-HIV on PI, or what you call protease inhibitor-based ARV regimens, nevirapine-based regimens, doravirine, etravirine, or tenofovir alafenamide. They should use 6H regimens instead. So I think this is an important part to note. We should not subject pediatric patients or CAL-HIV patients who are on PI-based regimens. PI-based regimens here include atazanavir, ritonavir, or even lopinavir-based regimens. Equally, if patients are on a nevirapine-based regimen, of which I believe now they have since been withdrawn, nevirapine-based regimens, we are seeing new usages of doravirine and etravirine, and we have also seen adoption of use of tenofovir alafenamide, which we call TAF, tenofovir alafenamide. So all of these patients on these regimens, it is advisable that they don't use 3HP. Instead, they should use the 6H regimens. So in terms of pretreatment requirements, you need to rule out active TB. That is upon clinical evaluation. At the same time, this clinical evaluation should be accompanied with a chest X-ray. Where available with those resources, you can do molecular testing. Equally, where available, you can confirm TB infection using IGRA or TST. I think the IGRA is it's an acid test, basically, if I can just mention that. For the TST is the TB skin test, or what was previously known as the MAN2 test. So in terms of documentation, you document contact history with the index TB case and type of resistance in the patient, TPT record card, and contact management registers. So to highlight here, something is that we are able to get the type of resistant patterns on testing the patients with GeneXpert test. So currently GeneXpert is able to give us a resistant patterns of whether there is an RR, that is a rifampicin resistance. I understand that they are adding on extra capabilities to this GeneXpert to also be able to identify isoniazid-based resistances. Yeah, so in terms of those pretreatment requirements, you need to do a baseline assessment, establish whether there is a HIV status, current ART regimen, if applicable, assess comorbidities, check for drug-drug interactions or DDIs. Equally, we are interested in pregnancy tests. Pregnancy test here, this does not allude to the fact that the 3HP is teratogenic in nature, but if there is a woman of childbearing age who tests positive, then as a guidance, they should be given the 6H regimen. For those who are not pregnant, you advise on a barrier contraceptive method, which proves to be more effective in terms of these outcomes. You also need to elicit allergies, find out whether patients have allergies or contraindications to isoniazid or rifampicin. So all of that should be done before you initiate treatment. So in terms of dosing and administration, 3HP is a once weekly administration for up to 12 weeks. That is 3 months. Exact dosing is 91 days. So the treatment should fall within that 91-day period. In terms of administration, it should be done on the exact same day of the week when it is started. It can be given with or without food. The target here is 90% to 100% of doses. 0 or 1 missed dose. So the goal here is to encourage no missed doses. And here the goal here is to encourage no missed doses because of the convenience of the once weekly treatment. So ideally, it should be 0, completion of the course within 12 weeks and a maximum of 16 weeks. 16 weeks here, we shall see later on, is because of the possibility of failure to use within the stipulated period. So crushing and dispersing tablets is acceptable for younger children. So what we are simply saying is that these are medications that are dispersible tablets, and they are compatible with being put in water. So this is the dosing schedule for the 3HP. So there is the weight. It is a weight-based dosing schedule. So we see it starts at 3 kg to 5.9 kg for an estimated age group of less than 3 months. The isoniazid 100 milligram dispersible tablets dispersed in 6 ml of water. No, dispersed in 10 ml of water, you give 6 ml. For the rifampicin 150 milligram dispersible tablets dispersed in the same volume of water, you give 5 ml. So those are the way the dosing bands are distributed across the different ages of the infant early life, that is the less than 3 months, greater than 3 months, but less than 6, that is the dosing of 7 ml. Then from 6 kilograms, that is 6 months, 6 kilograms to 9.9 kg, you administer 1 tablet of 100 milligram for isoniazid and 1.5 tablets of rifampicin. So it is the reason why we, from 6 months onwards, we are talking about this is because we have also now launched the child to weaning. Okay. So 1 tablet isoniazid and 1.5 for rifampicin. So the advisory here is that you disperse prescribed tablets in 20 ml of safe drinking water. Give the entire suspension using an oral syringe or a measuring cup. So we move up to 10 kg to 14.9 kg. You administer 2.5 tablets of isoniazid. The 2.5 tablets here amount to 250 milligrams of isoniazid and 2 tablets of rifampicin equal to 300 milligrams. 15 to 19 is 3 tabs for both drugs. 20 to 24.5 kg is 4.5 tablets for isoniazid and 4 tablets for rifampicin. And 25 kgs to 29.9 is 4.5 tablets for isoniazid and 4 tablets for rifampicin. So something of noteworthy is anything above 20 kg, the dose is constant up to 30 kilograms. The dosing is constant up to 30 kilograms. The note down there is that the dispersible tablets can be taken up to 30 kg, and some children weighing between 25 and 30 kg cannot swallow the adult FDC tablets. So those are the candidates for using these dispersible tablets. Yeah, so these are the weight bands of the FDC. 25 to 29, 2 tablets, 30 kg to 34, 2.5, 35 kg and above, 35 kg and above, it is a standardized 3 tablets to be dissolved or to be used by these children. So 35 to 39.9, 40 to 44.9, 45 to 49.9, and 50 kg and above is 3 tablets. The general advisory here is all dosages are co-administered with pyridoxine, preferably pyridoxine at 50 milligrams. Pyridoxine at 50 milligrams. So on the follow-ups to 3HP initiation, you monitor children weekly at a health facility and through community health workers. You align visits with routine child well-being clinics. Those are the MCH clinics or any other scheduled review. You screen for TB symptoms at every visit. If TB confirmed, you stop TPT and manage as an active TB disease. Equally, you're supposed to perform clinical assessments on hepatotoxicity. You look out for jaundice, nausea, vomiting, and abdominal pain. Yeah, that is very important because of the possibility of liver injury that may come with exposure to some of these drugs. Equally, you advise the caregivers to report adverse drug reactions immediately. So there is an active monitoring of PV incidences when patients are on these drugs. Of course, we know with rifampicin, there's the risk of the urine turning reddish brown. So that should be an information that should be passed to the patients prior to them starting the drug so that they do not consider that change of color of urine as an ADR. So in terms of management of 3HP interruptions, if there is one dose missed, if remembered, take within 2 days, take immediately and continue the original schedule. So if missed dose is greater than 2 days late, take the next dose immediately and shift the weekly schedule to the same day of the week to avoid subsequent doses being taken less than 4 days apart. So there is a guideline here. When there is 1 week missed, resume immediately, complete all 12 doses. When there is 1 to 3 doses missed, that is up to 3 weeks, continue until all 12 doses are taken and extend up to a maximum of 16 weeks. When there is greater than 4 doses missed, consider restarting the complete 3HP course. So I think that should come out very clearly. Wherever you miss up to 4 doses, that is, you miss up to a month of treatment, then you should consider restarting the therapy. Equally, on the issue of poor adherence, discontinue 3HP. When you observe that there is poor adherence as the monitoring clinician, you discontinue 3HP. Address the cause of the non-adherence and offer alternative daily regimen. In this case, being the 6H or the 3RH. So if you observe that as the guiding clinician, then you're supposed to remove the patients from that regimen. So in terms of the 3HP drug-drug interaction, these are the known interactions with PIs or protease inhibitors. They reduce the effect of 3HPs. On the 3HP, they reduce RFP levels, leading to decreased efficacy. And where there is a contraindication, hello, Dr. Lewis?
Yes, Doc.
You can hear me clearly?
Yes, yes.
Yes. So I think there's a notification that my audio is poor. That's why I keep getting back to you.
It's
So
okay,
in
Doc.
terms of the contraindications associated with nevirapine, co-administration of 3HP increases nevirapine toxicity. So that one should be borne in mind. And nevirapine toxicity is nephrotoxic in nature. Then the clinical complication here is increased CNS effects. So that's why we said PIs, NNRTI such as nevirapine are contraindicated, and instead patients on this regimen should be put on the 6 months of isoniazid. Doravirine is associated with reduced doravirine levels when co-administered with 3-HP, and therefore we observe reduced HIV suppression. So this here impacts directly in terms of wherever there is reduced HIV suppression, then we see a spike in the viral loads. Therefore, it is contraindicated in doravirine-based regimens. For etravirine, it leads to reduced etravirine levels due to reduced, the clinical implication being reduced HIV suppression. For tenofovir alafenamide or the TAF, we see increased TAF levels leading to a potential tenofovir alafenamide toxicity. So for DTG, we observe reduced DTG levels, which may reduce efficacy. The recommendation for DTG-based regimens is to maintain standard once dose daily of DTG, and studies show it will remain well above the minimum effective concentration required to inhibit the HIV virus. Other entities such as raltegravir, we observe variable effects, and this one should be reviewed on a case-by-case basis. So other entities such as raltegravir are used largely in third-line regimens, and wherever these third-line regimens are considered, they are usually subjected to technical working groups who come up with these tailor-made regimens for PLHIV on third-line therapies. In terms of contraindications to azole antifungals, we observe reduced azole levels, leading to reduced fungal coverage. You need to monitor. Recommendation here is to monitor and it may need dose adjustments. As pertaining to corticosteroids, 3-HP induces, it leads to induced metabolism. Remember, 3-HP is a regimen containing rifampicin, and rifampicin is in the same class with rifampicin, and both of them are considered enzyme inducers. So we observe a reduced steroid effect. Yeah, so in terms of adverse reactions and management, common adverse reactions here, we observe flu-like syndrome, that is fever, chills, and malaise. The management is purely supportive. You give analgesics, antipyretics, including NSAIDs such as ibuprofen, and antipyretics such as paracetamol. Other adverse reactions is nausea, vomiting, and diarrhea, which are observed to be mild to moderate adverse reactions. So where there is persistent diarrhea, you support appropriately with the loperamide. Where there is vomiting, you can give antiemetics, both the centrally acting antiemetics and the ones that have the other modalities of action. We also observe mild rashes, diffuse or non-bullous. Here you can manage with antihistamines, such as diphenhydramine, cetirizine, and also it has also been observed that there is a better management of these rashes when there is avoidance with direct contact with the sun. So maybe you can, where available, you can do a sunscreen, or you can wear clothing that shields the direct contact with the sun. So in terms of other adverse reactions, we observe peripheral neuropathies. Peripheral neuropathy here should be countered with the use of vitamin B6, that's pyridoxine, dosed at 50 to 100 milligrams daily. So the goal here is we realize that these peripheral neuropathies arise as a result of the use of isoniazid. Yeah, so isoniazid here, so to counter the adverse effects of the isoniazid in the regimen is why we administer the vitamin B6. Of course, isoniazid has to do with the absorption of vitamin B6, which is very critical in support of the neurological functions. So if there is a lack of absorption of dietary pyridoxine, then it is only wise that we do a supplementation through these synthetic pyridoxine. We also observe a change in color in the body fluids to orange-red. That is a standard observable side effect or side effect wherever patients use these rifampicin-based regimens, and the only thing here is to do a reassurance that that particular change in the color of body fluids does not in any way allude to injury of any organ, internal organ within the body. Yeah, so severe adverse reactions that have been observed is drug-associated fevers above 39 degrees or recurrent fevers. So you need to reconsider introduction of TPT if temperatures stay above 39 degrees. You stop immediately if fever recurs and do not reintroduce. Equally, there are cases of hepatotoxicity observed, hepatotoxicity and also hepatitis. So hepatitis here, we are looking at it in terms of the drug-induced hepatitis. So early signs include weakness, fatigue, loss of appetite, and persistent nausea. Late signs of hepatotoxicity include liver tenderness, liver enlargement, that's hepatomegaly, and obviously jaundice. So wherever these severe adverse effects are observed, you stop 3-HP. Consider introduction with caution if alanine and aspartate aminotransferase levels are less than 5 times the upper limit of normal in the absence of symptoms. Equally, you stop and you do not introduce if levels of the alanine and aspartate aminotransferase are above 5. As pertaining to rashes, severe rashes, that is bullous lesions, Steven-Johnson syndromes, and then I think this is a necrotic disease or a necrotic syndrome. Wherever you observe this SJS type of rashes, you need to stop the drug immediately and refer the patient to a specialist for evaluation. Equally, you need, we have observed psychiatric reactions being observed, such as psychosis, hallucinations, as well as seizures. You stop isoniazid and subject the patient to psychiatric evaluation. Other hypersensitivity reactions, such as hypotension, acute bronchospasms, conjunctivitis, and thrombocytopenia, you assess the clinical severity of symptoms. If they are severe, you stop the drug immediately, you stabilize the patient, and you consider introducing them to the isoniazid-based only regimen. So TPT for DRTB. So we are going to move here so that we can give time for Q&A. So globally, the estimated 450,000 incident cases of MDR stroke RR. Kenya reported 365 MDR stroke RR cases in 2024. The risk of progression of TB infection to TB disease does not differ among contacts in either DSTB, that is drug-sensitive tuberculosis or drug-resistant TB. Currently, TPT is initiated for eligible contacts of DSTB index patients, but now we see an introduction of TPT to DRTB patients. So this is some information to support the use of TPT or TB preventive therapy to MDR TB contacts. So up to 2018, the WHO recommended active surveillance for MDR TB contacts. Ethical concerns highlighted high risks in children and PLHIV were left untreated. And early observational data suggested potential benefit of fluoroquinolones, but evidence was of low quality. So the evidence generation here through those randomized trials demonstrated a reduced TB incidence in persons, in adults and pediatric patients, MDR TB contacts, and a combined meta-analysis showed 60% reduction in TB disease on persons with 6 months of levofloxacin. So the WHO issued a strong recommendation in 2024 for 6 months of daily levofloxacin for MDR/RR TB contacts. And that's where now we introduce fluoroquinolones as TPT or TB preventive therapy among MDR/RR TB contacts. So in terms of benefits, it has proven feasibility and affordability and acceptable safety profile. So equally, it has no clinically relevant interactions with antiretroviral therapy, supporting use in PLHIV. And in terms of program adoption, it had multi-country rollout upon the advisory from the WHO. And the next generation regimens, such as bedaquiline, delamanid, and in trials, equally, they are there to address the pre-XDR TB gaps. So this is a study, the levofloxacin versus placebo, that was conducted in December of 2018, sorry. There was also another study there, the levofloxacin versus placebo for the treatment of latent tuberculosis among contacts of patients with multi-drug resistant tuberculosis. The VQueen MDR trial, a protocol for randomized controlled trials. And the last one is a meta-analysis of levofloxacin for contacts on multi-drug resistant tuberculosis. So you can take time to go and review those studies so that you can be able to get the greater bulk of information on the justification for their use. So in terms of consideration for the use of TPT among MDR TB patients, TB contacts, the household contacts of people with MDR TB, that is adults, children, and people receiving immunosuppressive therapies. So the duration and intensity of exposure with close contact is considered. Index patient and their drug-resistant patterns, whether MDR or RR. And this should be done through confirmed bacteriological studies and confirmed TB infection using IGRA or the TB skin tests where possible and available. So that should be supporting information. Disease. Sorry, I keep checking the chart so that we can be able to walk in step. So for MDR TB contacts, eligibility or inclusion criteria, we need to rule out active TB disease, clinical evaluation and risk assessments of the intensity of exposure, resistant patterns. We are able to get these resistance pattern data from subjecting the patients to the gene expert tests. We're able to observe the RR or the isoniazid resistant patterns. So all MDR and RR contacts are already presumptive cases, and active TB disease should be ruled out before initiating this fluoroquinolone TPT. Chest X-ray is important in ruling out active disease, and its absence should not delay the initiation of TPT to eligible contacts. So I think this needs to come out very clearly that in the absence of a chest X-ray, in as much as it is important to rule out active disease, we should not deny any eligible contacts. So for the TPT regimen options for MDR, TPT, MDR TB contacts. So TPT regimen recommendation, you give 6 months of levofloxacin given once daily for 6 months. Remember, as we shall later on see, this is a weight-based regimen. So among contacts exposed to patients with MDR and fluoroquinolone-sensitive tuberculosis. So in terms of baseline assessment, you check on the resistance of the index patient and you rule out resistance. You elicit medical stroke social information relevant for TPT initiation. It is also advisable that pregnancy tests must be done at baseline for women of reproductive age. Equally, you need to assess for the presence of comorbidities and manage appropriately. So where available at baseline, that is at the point of initiating the tests, it's advisable you do the liver function tests, you carry out the urea, electrolytes, and creatinine tests. You can do an RBS, I think this is a random blood sugar, etc. They are recommended, especially among those with comorbidities. However, lack of these baseline results should not delay the initiation of TPT in asymptomatic patients who have met that earlier criteria we talked about. So in terms of eligibility for reinitiation, contacts who have received TPT due to exposure to a patient with DSTB. So you consider use of levofloxacin if this is a reinitiation. A patient has previously used maybe the 3HP or the 6H. If they are being reinitiated, then it is advisable you can do a reinitiation with levofloxacin. TPT initiation can be done anytime after completing the initial TPT course, provided there is documented exposure to a patient with MDR stroke RRTB. So this eligibility also applies to PLHIV who previously received isoniazid or 3HP as part of their TPT regimens. So I think there is no exclusion of PLHIV. So this is the dosing schedule, the dosing chart. As we had said earlier, this is a weight-based dosing chart. So we have a new formulation for levofloxacin at 100 milligrams as a dispersible tablet. And then we have the direct compression tablets, which are film coated, the 250 milligram tablets. So this is largely for pediatric formulations. So the dosing recommendation for use of levofloxacin in pediatric formulations for child contacts at TPT ages less than 15 years. So at the strength, the advisable strength is 15 to 20 milligrams per kilogram per day by body weight. So this is the flow chart from 3 kg to 5.9. You administer half tablet of the 50 milligram of the 100 milligram dispersible tablet above 3 months. So for 3 to 5.9, less than 3 months, you do half tablet. 3 kg to 5.9 kg. Above 3 months, you do 1 tablet of 100 milligram for levofloxacin. 6 to 9.9 kg. Above 6 months, you do 1 tablet. 6 to 9.9 kg equal to or greater than 6 months. No, so this is less than 6 months. So greater than 6 months is 1.5. And 10 to 14 kg, you do 2 tablets of levofloxacin dispersible. 15 to 19.9, you do 2.5 tablets at 250 mg of the dispersible tab. And 20 to 24.9, you do 3 tablets, that is up to 300 milligrams of the dispersible tablet. If in the absence of the 100 mg dispersible tab, then you can do the 250 mg tablet. That is a provided dosing for the 250 mg tablet. So you will find once in a while you have either all of these strengths of levofloxacin. The advisory is that all of these treatments are once daily dosages for up to 6 months. So levofloxacin adult dosing 25 to 29.9, that is 2 tablets equal to 500 milligrams. And that moves all the way to 45 to 49.9 milligrams, 45 to 49.9 kg at 2 tablets equivalent to 500 mg. So here we see any persons above 50 kilograms should get 3 tablets of 250 milligram levofloxacin. That is equal to 750 milligrams. So if we are going to give levofloxacin TPT to persons above 50 kilogram adults, it should not be less than 50. It should not be less than 750 milligrams. So for the 500 mg tab, for the same 50 kg weight band, you do 1.5 tablets. And as we had said earlier, this is an OD dose for up to 6 months. So in terms of drug interactions, we observe the absorption of levofloxacin is not influenced by food. So we don't have a food-drug interaction. No major interactions between milk or dairy products and third-generation fluoquinolones. Concomitant steroid use may increase the risk of tendon rupture, or what we also observed as tendonitis among fluoquinolones. Antacids, especially those containing aluminium, mineral supplements, e.g. iron or magnesium or multivitamins, may decrease absorption and should therefore be taken more than 2 hours before or after this medication. So what we observe with these drugs is that there is an aspect of formation of chelate complexes that inhibit the absorption. Of course, those chelate complexes, they end up forming those large molecules which cannot be able to pass through those membranes, and as a result, the drug availability significantly reduces. So this is observed among all mineral agents, or what you call metallic metallic minerals of supplementation or nature. So that's why there is an advisory to take 2 hours before or after medication. Levofloxacin may enhance the effects of warfarin. Warfarin here as an anticoagulant. So prothrombin time and international normalized ratios should be monitored, and the patient should be informed about the risks of bleeding. Which brings us to the fact that sometimes you may encounter a patient with bleeding disorders who may be in need of this drug. So whenever we encounter patients with bleeding disorders, they should exclusively not be put on levofloxacin. So as such, levofloxacin may affect glucose metabolism. Blood sugar levels should equally be monitored. Yeah, so adverse events or adverse reactions associated with this drug. We have GI symptoms or the gastrointestinal system adverse events associated with diarrhea. It is a relatively common phenomenon. Characteristic, it is mild to moderate and usually resolves. Equally, under GI adverse events, we observe nausea and bloating. It's a common thing. So you might want to adjust the diet that the patient is taking. Musculoskeletal adverse events is arthralgia, that's joint pain, it's common. usually mild, you monitor for tendinopathy. Then there is inflamed stroke torn tendons. It is uncommon, but you need to assess risk factors and you stop if tendonitis is suspected. Equally, under neurological adverse events, there is headaches and dizziness. It is common, and you give supportive management. Under cardiac, there is QTC prolongation. It is uncommon. You monitor baseline ECGs in high-risk patients and avoid QT prolonging antihypertensives or cardiovascular agents. In terms of sensory, there is altered taste, stroke smell. It is uncommon. It is considered a benign characteristic, usually resolving post-treatment. So it could be like an alteration in terms of the receptors of taste and smell, which restore upon the cessation of treatment. From hepatic system, we observe the adverse event here is liver enzyme elevation. It is uncommon, but if it happens, you monitor if baseline abnormalities are observed. So you need to make follow-ups for these patients. You monitor latent tuberculosis treatment monthly. You align visits with index patient care education, educating patients and families about disease, treatment and adherence. Advise patients to report ADRs and adverse events immediately for timely management. So that is the PV being incorporated as a component of care for these patients. You screen for TB signs and symptoms and manage appropriately with necessary tests. Emphasize adherence and completion for individual and program success. You address factors leading to poor adherence and also factors and concerns leading to poor adherence. Provide ongoing support to overcome barriers to adherence. You continue follow-up for up to 2 years after TB exposure with quarterly visits post-therapy. Yeah, so now it's important we measure the outcomes of any therapy we give. And for TPT, there are 4 outcomes that we look out for. Upon completed treatment, the description here is that an individual who has taken a full course of TPT in line with the guidelines. So if it is 6H, you have taken 6 months, probably with minimal interruptions. You have taken 3HP for 91 days or 12 weeks with minimal interactions. You have taken 3RH with minimal interactions. Then there is loss to follow-up. An individual whose TPT was interrupted for more than 1 month. So we are interested in those reasons or factors that brought about this interruption. Discontinued, an individual whose TPT was stopped due to adverse drug reaction, development of active TB disease in the course of TPT, and persistent non-adherence. So we can eliminate someone from TPT on these 3 grounds, and the outcome is noted as discontinued. And in the unfortunate event that a TPT user passes on, it should equally be noted that an individual who died in the course of TPT, irrespective of the cause of death, I need to highlight that, death irrespective of the cause of death, where it could be like an RTA, the outcome was death. It could be a death due to a comorbidity, the outcome is the same. So this should be noted irrespective of the cause of death. So reporting is very important, especially for PV-related issues arising, whether they are adverse drug reactions or adverse events. They should be reported in a timely fashion in the PV portals of the Pharmacy and Poisons Board. And the TB program also maintains a parallel system of reporting pharmacovigilance-related issues through the TBU platform. Yeah, equally, for any PV-related issue, it is supposed to be documented to the KHIS through the FCDRs, that is the Facility Consumption Data Report and Request Tools. as well as the facility monthly ARV patient summaries. So if an ADR happened to appear HIV who is on treatment and being monitored, that is when this ADR enters the KHIS through the HIV reporting tools. Special attention should be paid to documenting adverse events, HIV status, and ART regimens for children living with HIV. So this is the ordering cascade. A majority of the treatments for TB in Kenya happens in the public sector, as we had seen earlier, up to 76%. So this is a structure that supports the availability of drugs. The health facility generates data, reports it to the sub-county sends it to the county, that further pushes the information through the LMIS. The data is picked up at the national level. The LMIS, they aggregate through the NOMT. The NOMT is the National Order Management Team, Validation and Rationalization. They push those requests to KEMSA, that is the Logistics Management Information System for KEMSA, that then KEMSA is the umbrella body procuring these drugs from abroad. And then KEMSA does a sub-county delivery of the drug. So because the TB does not have decentralized supplies, all supplies are picked at the sub-county level. So all supplies of anti-TB agents are picked at the sub-county headquarters. So the roles and responsibilities of pharmacy teams. So the pharmacist here, the county pharmacist prepares county monthly health products and technologies consumption and order requisitions report, and subjects it to the Department of National TB and Lung Disease. They oversee implementation of SOPs for supply chain management and pharmacovigilance. They supervise HPT processes within counties, HPT capacity building for county and sub-county level staff, coordinating supply chain functions, and participating in patient multidisciplinary teams. Those are the MDTs and the technical working groups, the TWGs. The greater bulk of work is on the sub-county pharmacists. They ensure accurate HPT inventory records, keeping and timely entry into KHIS. They are the primary data entrants into the KHIS for both the TB programs and the HIV programs. They supervise implementation of SOPs and guidelines at facilities in the sub-county. They ensure timely ordering, stock status reports, and effective distribution, storage, and inventory management. So this has a lot to do with the day-to-day running of the commodities. If there are short expiries, they push them or create demand elsewhere, and ensuring basically the right steps are applied wherever we are managing TB commodities. They ensure appropriate use of TB commodities, coordinate pharmacovigilance activities, participate in HPT, capacity building programs at the health facility, and they participate in patient multidisciplinary teams at sub-county and facility level. Maybe just to put some greater weight, the TB program has a very deep appreciation of the roles of the pharmacist in the MDTs. And these MDTs are usually held especially for management of MDR and RR patients or drug-resistant TB patients. And the contributions of the pharmacy in terms of management of ADRs and the advisories that should be given when there is a need to change a drug are highly appreciated. So this is one of the roles of the sub-county pharmacy staff. So there's this particular, I think this one here was a slide that was just done to create awareness among healthcare workers. So you follow IPC measures to protect yourself so that you can keep helping your patients. If you haven't yet received your dose of TPT, do so at your facility or any nearby facility offering the service, and participate in the biennial uh, TB screening for healthcare workers at your facility. This is absolutely important, and I've seen a number of healthcare workers ignore, either as a result of not knowing or not giving it the level of seriousness that it deserves. And one thing I have come to know after working in the TB units for quite a number of time, a number of years, is that TB is never away. It is never away. And it is highly likely, if you have interacted with those patients at some point, it is highly likely that you could be having the latent form of this disease. So participate. Screening is not an invasive procedure where you have coughs coming up, even if they could be as a result of other indications. Just subject that sputum to a gene expert. You just need to suspect, you don't have to be sure. Yeah, so I think that is just my simple advisory to any healthcare worker interacting with these active cases in the hospitals. Hello.
Thank you very much, Dr. for the comprehensive presentation on latent tuberculosis infection. I think it's important to appreciate that the change in terminology. I think one of your slides highlighted that the term latency has been removed, so they are now referring it to tuberculosis infection, and that is
Yes.
to also include that the people who might have immune response to the TB without it progressing to active disease. So thank you very much for that presentation, and I'll move straight to the questions. We have a question from Dr. Rose Gerono Keter. Can a person use TPT multiple times? Like if they were living with a patient with active TB, they are given TPT, then let's say they contract HIV a year later, should the TPT be repeated? And then an additional one, then for persons like prisoners or healthcare workers who are always at risk for TB, how frequently should they get TPT?
Yeah, thank you for that question. So to address the first question or concern is that TPT can be repeated. Previously, the guidelines advised for TPT to be administered at least every 2 years. At least every 2 years. However, we have seen in this new regimen, especially for levofloxacin, it can be administered immediately after the patient has finished the other regimens. Remember, a two year gap is not really is not a very large duration of time. So the greater advisory was that you can repeat TPT after 2 years, and it has been effective, especially in persons who may be in what we would call a substantial ongoing risk of infection. However, if there is a significant risk, like where we observe a patient who had TB, DSTB, getting reinfected, then the contacts can, upon the reinfection of this index patient, then the contacts should also restart the TPT. Yeah, so I think it can be restarted. What we just need to look out for is to ensure that we support these patients, maybe with drugs such as pyridoxine, because you see extended use of isoniazid-based regimens can bring about the risk of neuropathies. So majority of these patients should be supported with the use of isoniazid-based with the use of pyridoxine to avert the neuropathies arising with isoniazid. So I think it can be done that. So on the same thing about persons living in congregate settings, I think the 2 year period applies. However, if there is a substantial ongoing risk, in those settings, like an inmate who has come in after you have finished, an inmate with tuberculosis who has come in after you have finished your TPT, I still think there is a room for restarting it, as long as the patient are supported appropriately so that any ADEs that can potentially arise as a result of use of the drugs do not arise. Of course, with the second, third exposures to TPT, we should also be able to support the patients more in terms of diagnostics to help us understand the functions of the inner organs like the liver and the kidney. So, if the patient is supposed to repeat the TPT, so it is also my feeling that it should be considered like a new use. So they should be subjected to those tests we talked about, the LFTs, the UECs, and the random blood sugars as part of the baseline profile testing. Is that okay?
Yes, Dr. Thank you. We have another one from Dr. George Mugendi. He's asking, did you mean 25% of the global population has latent TB and not clinically active TB? I think this refers to your slide on the burden of TB.
Yeah, on the burden of TB, so you can just go that. Let me just go there.
I think that there's another one
Mm.
where it was highlighting on the burden of TB infection. Just next, just go down.
Oh, down, huh?
Yes, yes.
I think it was this one.
Next. Not that one, just next. After where the TPT was introduced.
Okay, this one.
There, the previous one. There.
This one.
After this definition of key terms, I think the first bullet. This
Oh,
one.
this, yes, yes.
Yeah.
So
So
I
did
think
you
this,
okay.
yeah. So this is in general terms, the general population of the planet. Yeah, so that the other numbers about now, the clinically confirmed cases are the ones which now become a subset of the, remember this is the estimated burden of latent tuberculosis. Okay? If I get, or rather this tuberculous infection. This is the estimated burden of latent tuberculosis. So those who turn active are a subset of this tuberculosis infection. I don't know whether that is a clearer explanation.
I think it is, Dr. Ari. But just a follow-up, does it mean that all symptomatic cases have to have had an infection that maybe festered for a duration of time before it comes out?
Yeah, so I think there are two ways of understanding this. So there is first, there is what we would call, the better word is not spontaneous, but there is a TB infection in the absence of latent disease. Okay? TB infection in the absence of a latent disease. Then there is TB infection preceded by latent disease, if I can use such a term. So it is not a must that you get a first-time infection in the presence of a latent disease. It is not a must. It could be a first-time infection that was sufficiently that found the body in a sufficient state where probably sufficiently low immunity, then an infection set in. Yeah, so it is not a must that to have active TB arising in the presence of a latent disease. So I think that needs to come out clearly, and just the way we observe also, once the patients have a patient who has been treated of this latent TB, the assumption is that after these 12 weeks of treatment, you shall have attained that outcome of cure. Okay, you remember when you talked about that outcome of cure? So it is also possible that this patient who has attained that outcome of cure becomes TB infected. That will be an infection outside the risk of latent disease. So that's how I would like to look at it.
All right. Thank you for the clarification and distinguishing the two. Another question from an anonymous attendee: should contacts of MDR and XDR TB receive TPT?
Yes, I think that's what we have been talking about here, the use of levofloxacin to contacts of MDR stroke RR. That is a new guide update. Previously, those contacts were just being observed. But now the guidance is that use of fluocinolone levofloxacin has been found to be sufficient in preventing the risk of a disease arising. So yes, the contacts of MDR and RR can use levofloxacin as the TPT for all populations of pediatrics, adolescents, and adults, as we have seen in those regimens and dosing schedules.
Is XDR included, or is just MDR and RR?
Currently, it is just MDR and RR. XDR is not yet included. It's not included. Remember, XDR is a resistance to a fluocinolone. Pre-XDR and XDR have to do with resistances to fluocinolones. So unless the contact had been exposed to a pre-XDR case, of which now it should be done on a case-by-case basis to determine whether, I think there's a place I had talked about it. I can just go to that slide. TPT. Let me just go to that slide so that we can be able to look at the that is a place we had talked about the XDR. Yes, this slide here, slide number 40. When you look at this programmatic adoption and scale up, let me put the full slide. When we look at the programmatic adoption and scale up, there is that note down there that talks about proven feasibility. Those are the benefits of the program: proven feasibility, affordability, and acceptable safety profile for levofloxacin. The drug has no clinically relevant interactions with antiretroviral therapy, supporting use in PLHIV. Then there is that note on next generation regimens such as bedaquiline, delamide, and in clinical trials to address pre-XDR TB gaps. So my feeling is we may not be able to employ fluoroquinolones, being the fact that fluoroquinolones form the basis of the XDR status to these drug-resistant forms of TB. So in its place, if a patient is now exposed to, if a contact is exposed to an XDR TB case, then we should consider this next generation regimen such as bedaquiline and delamanid as possible agents for prophylaxis or TB preventive therapy. That's how I understand it.
All right, Doc, that's quite clear. Thank you.
Yes.
Tuko na swali kutoka Daktari Ndegwa Njenga na yuauliza, je, ni
Yes.
kwa nini madawa haya ya TB hayawezi kupitia famasi za jamii? Kwa nini mfamasia katika famasi ya jamii haaminiki na madawa haya ya TB ilhali amehitimu? Kupitia mafunzo kama haya, famasi zinaweza kusaidia katika vita hivi. Hili linafanyika na madawa ya kupanga uzazi.
Yes.
So why not extend TB, the collaboration between community pharmacies and the TB program, as we have seen between the family planning and the community pharmacies?
So maybe I can approach this in terms of the way the TB management programs have been run by the government. Yeah, so currently, the government operates TB therapy through a clinic-based approach. Okay, it approaches TB therapy through a clinic-based approach, and the benefits or limitations of a clinic-based approach is that it is an all-inclusive under one roof type of treatment or type of care. So we have labs being done there. We have nutritional counseling being done around that time, around the TB clinics. We have pharmacotherapy, of course, from the guidance of the pharmacists on ground. We have clinicians who are able to carry out diagnostics and able to manage complexities associated with tuberculosis. So being the fact that this is a disease whose model of care is approached with the a clinic-based approach, my feeling is that a pharmacy would be limited in terms of these other additional services that the TB patient requires for the holistic care that they require. That is how I like to look at it. And then number two is the fact that a majority of these medications that are issued through donor funding, which is how we get a majority of the TB drugs we use, also institute structures on how these drugs will be used. So as a collaboration between the donors and the Ministry of Health, there is a general direction in terms of how they feel the best approach to care will be. And of course, there are other challenges like if they will be accessed through the community pharmacy, which is a very nice way of looking at it. Will there be a cost imperative associated with that treatment? Because currently TB in Kenya it is cost free. You know, a patient comes and they are given all services under that one roof, and they are not charged because the services are under this quote unquote a program that is already funded end to end. So in terms of cost implications and the risk to adherence and other things that can come up as a result of how the community pharmacy would approach it, I think that is one way the government chose to approach it from a hospital-based type of care. However, it would be ideal maybe as a pharmacist who has served in the chest clinic. What I can ask is maybe from the second for DSTB, drug sensitive tuberculosis, post intensive phase. That is where maybe I can make a recommendation uh, for 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 treatment in a pharmacy setting. You know, otherwise for the full treatment and early diagnosis, it would only be best if we have a very quality time with the patient to bring them up to speed with understanding the disease and managing any other condition that they could be having at the point of contact with the patient. Yeah, that does not mean that the pharmacists are not adequately equipped. I just feel pharmacies are just an appendage in this whole treatment program.
All right, thank you, Doc. There's some questions in the chat box. Dr. Zakayo Shisoka asks, what happens to kids below 1 year who have exposure to TB? That is, they are contacts of a bacteriologically confirmed case.
Yeah, of course, when we first of all, we determine whether they are contacts of the drug sensitive tuberculosis or MDR or RR cases. And based on what we observe, they will be treated with the appropriate dispersible medications available. If it is DSTP, DS, drug sensitive tuberculosis, they can be given the 3HP dispersible tab regimens according to those strengths of the tablets that we had talked about in terms of the dispersible forms. If it is MDR, if they are contacts of an MDR, they can be treated or they can be managed with the dispersible levofloxacin that we had talked about. So yes, and the children under 1 year who are contacts, they are now covered. I think from 3 kgs and above. And 3 kg is definitely a very young baby, a very young child. Maybe a month going or go onwards, or 3 months going onwards. So they are covered. They can be given the TPTs to prevent any potential infection.
All right. Dr. Rose Sikolia asks, to reduce the pill burden and improve adherence, is there a possibility of FDC formulations as opposed to single molecules? I think this is with respect to the rifampicin and isoniazid that has been introduced for children and adolescents. Especially for children, there are distinct tablets.
Yes, so it would be advisable to have it as an FDC, but currently they are coming as a single. They're coming as single formulations, single drug formulations. However, we have FDCs for adults and persons above 25 kg. So the current FDC for 3HP is not a dispersible tab, but I want to believe as we move along, probably they can come up with a stable formulation that can be made into a dispersible tablet. But currently, I think they are separate and the pill burden is significant, but I want to believe just as they came up with an FDC dispersible tab for RH, they will also get one for 3HP.
All right, Doc, thank you. Then we have Dr. Apollo Chiang asking a question on the drug-drug interaction between 3HP and TAF. Is the consequence an increase or a decrease in TAF levels? I thought the risk will be potential reduction in antiviral activity due to decreased TAF levels, since rifampicin is a potent inducer? Kindly clarify.
Yeah, so let's just go back to that slide. Um, let's just go to that slide. Yeah, so I think this is what he's asking about. Tenofovir alafenamide. Yeah, so maybe I can give us a brief background here. So the change from tenofovir disoproxyl fumarate to tenofovir alafenamide was advised on the grounds of potential, I think, nephrotoxicity associated with the disoproxyl fumarate, and the fact that alafenamide-based regimens have lesser of that risk. So the fact that 3HP is a drug inducer, from that logical line of thought, it would mean that the excessive, the cytochrome 3AMP450 would remove the alafenamide from the system. But what we would like to appreciate here is that there are other background studies that have shown that the presence of the potential for tenofovir alafenamide toxicity in the presence of uh, isoniazid. This is not exclusively, what can I call it now? It's not like an exclusively identified problem across major populations, but given the fact that there is a potential for an interaction that can lead to an increase in toxicity, then it is on those grounds. It is on those grounds that tenofovir alafenamide would lead to an increase in the total serum concentration of TAF in circulation, leading to a potential toxicity. However, I would like to highlight that this is not static. I will also go back and look at other studies that have made this claim, and to look at whether this is something of concern, unlike if you're using tenofovir disoproxyl fumarate. So I'll make a follow-up on this, and maybe in another forum we can be able to contribute more positively on the same. But I know there exists drug interaction between isoniazid and tenofovir alafenamide.
All right, thank you, Doc. And finally, we have Dr. James Githinji asking, please comment on levofloxacin with regards to meals, including milk. I think this is the fact that you mentioned there's chelation with the heavy metals.
Yes, yes. So I think let me just go to that slide so that we can be able to get. This was on the slide we talked about. Sorry. Here, this one here. So what we have observed is that it's not just limited to this fluoroquinolone, but there are two ways of looking at it. Antacids are largely alkaline agents. That's really what they are. And in this case, aluminium-based antacids are the most common, a mainstay of the antacids in the class. Now, A majority of these drugs also have an aspect of ionization with them. And wherever you have any agent, whether a drug, food, supplement, or anything, having an active component of ionization, it also means that it can potentially form compounds as a result of these ionic natures of the chemical components making up these substances. So what was observed, especially in regard to metals, is that there was a potentiality for formation of complexes, those chelation complexes that as a result of the bulky molecules coming out of this complexation, it inhibits absorption. So I also want to believe in terms of milk products that contain calcium, there may be a marginal aspect of complexation with the calcium, and as a rule, if I can mention, we do not administer any drug with milk. We administer drugs with water or things like porridge and such like things. And that's because milk in and of itself contains a majority of these mineral elements that and also other compounds that may be potentially ionized. So as a rule, if you are to take a milk product with any drug, not just these fluoquinolones or the tetracyclines and the others, it is advisable that it is taken at least 2 to 3 hours before or after the administration to prevent any potential risk of these dissolved ionic products in milk presenting an interaction with the drug. So the advisory with milk products is that it should not be taken concomitantly. In as much as we say that there is no interaction, it should not be taken concomitantly because of that back-end risk of those dissolved substances. Of course, it depends with which type of milk product. The most active of these would be milk itself. Other processed milk products may not pose a significant risk, but whole milk, I do feel it should be given a significant leeway. Ipeanwe baadaye. It can be taken at least 2 or 3 hours before or after taking the drug. Back to you.
Thank you very much, Dr. Timothy Muriuki, for answering the questions. And I'll just read some acknowledgements from the chat. Dr. Shiundu says the presentation is quite educative. Kindly share the slides. Thank you. Dr. Kanja says excellent presentation, very informative. Imtiaz Ganiwala, excellent. Please share slides if possible. Mutuma, very informative presentation. George Matimbai, excellent, very informative. Ayan Isaac, excellent presentation. And Dr. Rose, very elaborate, informative presentation on the changes in TPT guidelines. So, Dr. thank you very much for taking us through quite a comprehensive presentation. You can see more acknowledgements are coming. Hassan Mohammed says, good presentation. And to the members who are still with us up to now, I want to say thank you very much for joining us this evening. I know we've stretched it a bit, but thank you for staying with us till the end and till the Q&A. And I'd like to close this now, and I'd like to wish everyone a pleasant evening and a good night. Thank you very much.
Asante sana. Thank you and have yourselves a good evening.